Women in your 30s and beyond, are you tired of being told how to feel? Like all of the products are forced on you? Doesn't it feel like these big companies categorize you when the truth is they don't know you? Listen up. I'm Dr. Jila, an OBGYN and women's health expert. This is my podcast, Her Time, Her Health with Dr. Jila. Before we dive into the science of everything, I always love to start here, especially with you. What first called you into reproductive medicine? Because, it's not just a regular specialty, right? It's a space where you kind of walk with your patients through a lot of different emotions: hope, grief, resilience, possibility, life-changing moments. So what drew you into this field?
Yeah, that's a great question. So I was lucky enough to find out that I had PCOS, polycystic ovarian syndrome, when I was really young. And how that happened was my parents got a divorce when I was hitting about to hit puberty. And we had a lot of life changes because my mom was a housewife. She got married at 16. She had me the year after. She's always home with us. So we moved, and we had never lived in Chicago. We moved all over the country because my dad he was in pharma. So we moved to Chicago where her family was. And then she started working 2 jobs and, was never home. And I was the oldest, kind of helping with my siblings. And just, it was very different from the life we lived. So she thought, oh my God, finally at 14, she's like, my daughter's not getting her period. Something's wrong. Mm-hmm. Everyone else around her is. So she started taking me to different doctors. She took me to the pediatrician and they're like, oh, it's fine. Then I remember her taking me to another doctor and they're like, just to give her birth control. And she wanted to know the why, like what was happening. And finally someone said, you need a fertility doctor, a reproductive endocrinologist. And you're in the field. So, back in the day, REIs did everything and not just fertility. So I remember being this 14-year-old girl walking into this fertility doctor's office. And back in the day, do you remember all those posters on the walls? Yeah. So I saw a baby being born, a birth canal. I saw a vagina, and I'm like, oh my God, where did my mom bring me? And I remember when she walked in, she asked my mom to step out. And the first thing as soon as my mom stepped out and she was coming to ask me questions, I said, what do you do? Never been in an office like this. And you could even tell sitting in the waiting room, it just had so much emotion there. So I was like, what do you do? And she said, I make babies. And that was when I was completely mind blown. And I was like, what do you mean you make babies? I thought God made babies. And she's like, no, I can put 2 cells together and I grow them in a lab and it becomes a baby and I help build families. And from that day on, I remember saying, I want to do what you do. I want to make a baby and I want to practice this type of medicine. So that was my why.
Oh, wow. That's an amazing story because you were so young and, to be in that kind of place and then in that, but I have to give your mom credit to be able to make that distinction. Hey, I want to know the root cause of what's going on with my daughter. I just don't want to treat it and move on. Yeah. Wow. Bravo to your mom. Amazing. I love that.
And I always think about that. I was like, wow, to be that intuitive, to be like, there must be something more. Not that birth control is bad, but tell me the why and I'll do it.
Exactly.
I think that was important.
Okay. And so, now, fast forward, we met a little while back in Chicago, your hometown now, and I was immediately awestruck with you because of just your presence and just the way you relate to people right off the bat. And I get a vibe about people, a sense about people, and I got that with you and the way you spoke about reproductive endocrinology and the background to everything and how you really approach your patients with such warmth and hand-holding. And, from there, you must have been building what you have now because now you have new offices and new practices opening up. Tell us about all of that.
Yeah, well, I'm going to start by saying thank you. You gave me chills by saying that. I also get feelings, and when I met you, I was like, she's going to be a good friend for a very long time. So I'm so impressed by what you're doing and just how you advocate. And I think that's so important. I think that's where my why stems from, that when I ended up eventually being a patient, although I knew my entire life almost that I'm going to need fertility help, because I left that appointment with her saying, when you grow up and when you try to have kids, you're going to need me. Right. And that's how she left it. So that was ingrained in my head that I'm going to get married and I'm going to seek out fertility help. But navigating that journey became increasingly difficult because although I had over a decade to prepare that I'm going to see a fertility doctor, no one kind of warns you about the ups and downs of that fertility journey and how extensive that journey can be and how tolling it can be, not only financially, but emotionally. And I think how I try to practice is everything that I felt, not just how I was treated, but just felt, right? Like, because how you feel is what will stay with you forever, and how someone makes you feel you will carry forever. And how I felt at each appointment, at each negative, at each step, what I tried to do is I tried to take that and operationalize it and implement processes to build a practice that will hopefully never make somebody feel like that. Are we perfect? No, but I've been able to do it within my own small clinical practice within a big network. And over time, it's served really well. It's continued to grow. Patients come to me from all over the world for that feeling, for that operation, for somebody who's going to be their partner and fight with them and educate them. And then just with the last decade, kind of doing it on my own within a practice, I'm like, it's just time to do it on my own and teach others so I'm not the only one doing it, right? Like, why not create a practice where other providers also believe in the why?
Right. And so your patients and your in the new offices, I mean, they're so fortunate to have this kind of compassionate care available to them. Are you staying local, or do you think you're gonna, do more with it nationally?
I'm in Chicago and in Denver right now.
Okay.
My goal is to continue to grow. I actually have a huge following in South Florida because our
Mm-hmm.
goal was to open in Florida. I trained there, so I have a lot of friends
Mm-hmm.
that live there. So hopefully Florida, New York, I have a big following. Texas, I have a big following. But first is grow Chicago and Denver, and then
Mm-hmm.
eventually start scaling.
I am so happy and I'm so proud to know you now. And now I know with my young, because, even in my new office, my goal was for midlife women, past reproductive age. But what I'm noticing is they're bringing in their daughters. They
Yeah.
want the same kind of care for their daughters. And, we know fertility can change at any point in time. And you never know, even if you had regular cycles, when you're trying to have a baby in your mid 20s, 30s, something could happen if that's for you. So now it's nice to have resources such as yourself, where I'll be like, okay, I know where I'm going to send you and you're going to get the appropriate care that you need.
Yeah.
Because I like having my little network of people who are of my own same mindset, I think,
Yeah.
because my patients like that. And I know that's what they're seeking out. So it's good to know that hopefully we'll have you down here in Florida
Yes,
at
I
some
would
point.
love that. And
Yes.
I love that how you're just not focused on your patient, but like, how does it impact the younger version, their daughters, right? Because
Yeah.
that was my whole thing. Like, I only see them in infertility. And then I would always say, well, what this means for you long term is you may hit menopause sooner. After you deliver, you'll feel XYZ. And I could never carry that care on. So I love being a part of a network like you to say, this is where you go and this is how they're going to manage you.
Right. Right. Yeah, because we're seeing women are having babies later and later. And some of them go from that postpartum into perimenopause pretty quickly, and they don't, it's not being picked up and it's not being diagnosed appropriately, I think, in a lot of instances. So I'm glad that we're making those improvements and those, connecting the dots for women out there so they know the care they should be seeking.
Yeah.
What are some of the biggest misconceptions women still carry about infertility?
One of my biggest, and what I'm really working hard to change is that infertility is right now how it's positioned. It's very reactive. It's like prepare your body to have a baby for 3 months, right? Like take a prenatal, take out your IUD or stop your birth control, stop all this behavior, and then try and get frustrated and fail, and then see a doctor for getting tested and then get referred. That's like 3 years. So by the time they come to me, you sounds crazy, but they're like, oh, we've been trying for like 4 years and we've been trying for, so I'm trying to take a really proactive approach. Because even when we do our testing, majority of the time, we don't find a smoking gun, right? It's not like, oh, you have this or you have that. But one of the things that I felt was I knew I had PCOS. I went straight to the doctor, but it was, oh, you're so young. You don't need it. Oh, you're so young. But it wasn't my age. It was something that was missing. I wasn't ovulating. So independent of my age, I needed intervention. So trying to change it from being really reactive to more proactive management, just like you do with your educational content, right? Like expect this, know this is okay, know this is normal. It's okay to ask about your fertility markers. And the reason why, and I don't want to speak for you, but I think the reason why this longevity arm is so important is because your reproductive health is a biomarker of your overall wellness and longevity, right? Like, so when people are like, how does longevity tie to fertility? I'm like, what do you mean? Of course, it's your ovarian span, like the lifespan of your ovary ties to your overall health. Like for me, my eggs didn't work. It's not an isolated thing. They don't work because in addition to having my infertility, I have metabolic syndrome, I have high testosterone, everything's impacted. All of me is. And so that's what I hope to accomplish and teach patients, that it's not reactive. It's more proactive management of your overall health.
And that's, I think, the way women's health needs to be spoken about is proactive, not reactive, because for far too long, we have been reactive. There's a problem. Now let's go figure out what's going on. Yeah. Even with infertility. Oh my gosh. I will never forget the heartbreak of seeing a woman have a miscarriage and then being told, we're just going to keep an eye on it. You need to have 2 more to diagnose it and then to send you to the IVF clinic. And once I became a mom, I was like, that doesn't work. No. 1 is more than plenty. You should never have to go through that heartbreak over and over again. And then, okay, now let's say these were, these concrete things I think that we were taught in residency and training where, we have to actually start thinking for ourselves and say, okay, in clinical practice, does that make sense? No woman wants to feel that way. So I think 1 is more than plenty in my mind. And that's what I started doing. I was like, you know what, this is enough. And if I couldn't find any kind of progesterone deficiency or anything else to that effect that I could manage, then you're going there. They're going to evaluate. And even if, and again, we know the number 1 cause of infertility is typically unknown. Majority of them is we just don't know. And it is what it is. And we work with it. But at least if they're there with you sooner, getting this, this proactive management, they tend to do far better than waiting 3-4 years by the time everything happens in order to then be, siloed over to you. I think that's a lot of what we see too, is medicine is practiced in compartments. Yes. It's so compartmentalized where women are a whole person. And what you said, it's not just affecting you from ovulating, it's affecting metabolic syndrome, insulin resistance, high testosterone, everything and anything. And we were just so trained to do one thing at a time and not, look at the overall picture, that now we're taking a step back. And I think that's how we work so well in taking care of our patients, is this global view, not just one part to the other. As we know, it's all connected. What do you wish every woman in their 30s knew, regardless of whether they want to have kids or not?
I think that's important to know, that you don't just need a fertility doctor or to see a gynecologist once a year when you're ready to have kids, or that pap smear you may have forgotten about, that we take care of all of you, that all of these systems are connected. So you may or may not want to have a child, but testing your ovarian health is not just a function of a child, right? Like my mom, I just found out very recently, had menopause early and now is really struggling with osteoporosis. And she was done having kids. So she's like, oh, it's the period. I don't need it. I'm done with kids. But little did she think, oh, this is related to my cardiac health, my metabolic health, my bone health. So fertility, once again, is not, I'm going to say this over and over again, and I know you're going to be screaming this on the rooftops with me, that it's not just to have a baby. It is truly a marker of your ovarian health and your function, right? Like you may not want to have a baby, but I know no one wants a hot flash and bone thinning, right? So understanding and seeing me or seeing you is not just when you want to have a baby or when you've given birth or a pap smear, but it's to understand your body.
And I love the fact that we're all talking about women's health in terms of longevity care.
Yeah.
It isn't just hormone management for symptom management. It's rather underlying disease prevention. This has been around for a while. There are a lot of buzzwords and everyone's kind of jumping on board the longevity train, and I think that's wonderful. The more in the space, the better we can take care of all women nationally and globally. But you mentioned it, your mom, the osteopenia, osteoporosis. So all of that, these are things that are starting to build in our 30s and 40s. They're little hidden signals that then develop much later in our postmenopausal time. Do you see, and you mentioned it, but I want to get more into the ovarian reserve as another vital sign for women, basically?
Yeah, 100%. That's exactly what it is. It's a biomarker, right? Like we're all into these buzzwords. Like I want to know my biomarkers, but your AMH is just not your ability to have a baby, but is a biomarker of what's happening in your reproductive function. So, and that's important because a cycle is needed and important, not just to conceive, but it tells us what's happening, like a heavy, painful period. Do you have endo? Irregular cycles, what's causing it, right? And they, like you said, all of this is more proactive because later on, then you mount the heart diseases and the bone thinning, and you don't want that. You like seeing us at that point, is much harder to fix and treat.
Right. Are you seeing more and more cases of endometriosis, PCOS, and earlier onset of infertility issues with your patients?
I am. So typically, even right now as it stands, average time to diagnose a patient with endometriosis is 7 years. Isn't that crazy? Like to think somebody suffers for 7+ years and then they finally get diagnosed and then they don't feel crazy. With PCOS, even though it's so high, right? 1 in 10 patients has PCOS, even to diagnose PCOS on average is 2 to 3 years, which these numbers are like huge. To be like, oh yeah, I was, because a lot of people don't know. And when I say that, like when I say, oh, you may have PCOS, the first thing I get is, well, I'm not really obese and I get my cycle, and I'm like, well, those aren't really not the diagnostic criteria.
Right.
So I think it's important to know that, yes, I am seeing these, but I don't know if it's just because of how you and I practice, try to be more proactive. So those are the type of patients we attract. I would love to eventually be exactly what you said, so everyone has access to this type of care and thinking.
Right. And I think in terms of our environment and our food source and everything like that, that plays a huge factor in these numbers being so staggering. It's not just that we're diagnosing more. I think there's just more of it based on what's going on around us. Girls are getting their periods earlier and earlier where we didn't have that before.
No, there's so much, and there's so much in our food that we don't think about, right? And I always tease and say, if you're seeing me now, you probably grew up on McDonald's and fast food and Taco Bell, right? Because, and that was okay, but all those have so many preservative and so many growth factors, and that quality just wasn't there. So I'm always so happy to see that we're learning about what to put in our body, what not to put in our body, and we're so much more mindful of that now than before.
How do you approach your younger patients in terms of lifestyle modification, nutrition, things like that? How do you talk to them about incorporating that and the impact that it can have on their health?
Yeah. The first thing I always tell my patients is try to focus on things that you could do long term. One of the biggest mistakes I used to make and made was going on these short term diet trends to try to get to a certain goal, whether it was to stabilize my sugar and going all keto, or whether it was, oh, it's my insulin and trying to cut out all my carbs, knowing that, there's such a critical part of, I'm Indian, like that's most of our food is carbs. Right. So I always say, okay, well, let's start with what's proven. Mediterranean diet has been proven time and time again to be the best and only proven diet for fertility. So let's start with that. And then think about the longevity of being in a Mediterranean diet. What does that stand for, right? So it's foods lower on the glycemic index, more fishes for your omegas. We know we need the omegas for the cholesterol pathway and for your hormone building, right? So things like focus on that. So that way, if you have one day of eating pizza, totally okay. Then you can say, how can I make it more Mediterranean? Like I always go for my thin crust, my, like my mozzarella cheeses and olive oil. So it's longevity of following that certain type of food. I love getting my nails done and saying, oh, I used to go on these things where I'd say, not going to get my nails done. I'm not going to get my hair dyed. And then I would have a failed cycle or a poor outcome. And then I would go exactly the opposite. So now I say, well, when you get your nails done, look for these types of toxins that they don't have. Ask for this type of polish. So once again, then you're thinking of more lifestyle modification instead of this quick fix.
Right.
Right.
Yeah, so, because I think we can't be extreme. You can't live that way either. I think there has to be a somewhat balance in what we do and how we live. Don't, not eating fast food all the time is exactly, where we should kind of start. Sodas, things like that. Let's have some hydration and do all those things and active and be outside and get the, sunlight and grounding. And then, then you go and make different changes, right? And now we're lucky, we're fortunate enough where there are healthier options for a lot of the things that we do. That we didn't have, 10, 15 years ago. So we're moving in the right direction, at least.
Yeah.
So I know you're at the forefront of innovation. So I need to ask, what breakthroughs are really exciting to you that are upcoming?
Yeah, there's a lot. Where do I start? I think one of the things I'm most excited about, and I'm sure it's all over the news and you've seen it. There's a clinic called Gameto, or not a clinic, sorry. There's a tool called Gameto where it's almost like a needle-free IVF. So you take, they essentially mature your eggs in lab and then create embryos and then get you pregnant. So it almost tries to eliminate and shorten that time span. And there is actually a live birth or a couple live births with it. There's clinical trials going on. So I think that's really cool. Another thing I'm very excited about and to hopefully go see soon is something called Conceivable. It's a robot that does ICSI. So one of the rate limiting factors right now is the number of fertility doctors we have. So we have patients waiting months to get in to see a doctor. And then the other limitation is we don't have enough embryologists. So some places batch or some places cap. And once again, it's really not fair, to sit here and try to think about, well, I can't get access to care because there's a shortage. So I think having something that provides a better service, not better service offering, but to eliminate all these barriers to treatment, right? There's also some states that have no fertility practices because no one wants to go to a certain area. And so finding a doctor and an embryologist going there is really hard. So I think when people say access to care, they also almost always think about, access means insurance, access means cost, but they don't think about the barriers to access. And I think a lot of these are solving for that.
Okay. What will fertility care in your mind look like in 10 years if you had your ideal world that you have built and, all your practices are in every state? What will that fertility care look like?
If I would, this is going to be really, really big. The goal of practicing the way we practice like this, for me at least, is to hopefully eliminate myself, right? Like in a perfect world, if you said, Ruhi, what do you hope to do with this? Is to spread. I mean, there's always going to be cases where patients need me, but not as many people need me. And I think that's truly access, early intervention, education, and that makes my job much easier, because then I don't have to sit there and tell you, like, you'd be baffled. Like sometimes when I tell a 44-year-old or 45-year-old, like, take home baby rate at your age is less than 5%. And they're like, what do you mean by that? Right? Like, so my goal is to not have those type of conversations, to be like, oh yeah, I remember when you froze your eggs or embryos, or remember when I had the ability to intervene earlier. So that, in a perfect world, is my solve. That's what I'm trying to solve for. So to have a practice in every state, but to be able to offer from access and a cost standpoint, early intervention and patient education.
Okay. I have a couple of rapid fire questions for
Okay.
you before we wrap it up. One fertility myth you want to retire forever.
That it's a woman's problem. Takes two. Believe it or not, I still see saying, test me, it's not my partner. I'm like, how do you know that?
Yeah.
And men age just like women age. So it can change over time.
Right. Okay. I like that one, actually. A supplement you actually believe in.
You're going to think I'm crazy, but I'm a huge fan of NAD. I'm obsessed with it. I think it's been a game changer for me. I've actually seen physical results where patients who never made normal euploid embryos started making euploids. I know there was a paper that just was published showing a clinical trial of better blast and higher mature eggs, which both are a testament of quality.
Right. And what version of NAD?
I actually like the IV infusions the most, where the absorption's a little bit better, or the precursors, NNM.
Okay. The most underrated predictor of fertility.
The most underrated predictor of fertility. I think we hear about AMH as a buzzword a lot, but then when I ask patients, what's your FSH? They look at me like I'm crazy. So I know a lot of people, as fertility doctors in our world and as OB-GYNs, we know what it stands for, but I don't think we do a good job of educating our patients that FSH is equally important to your AMH.
And one last one. Something women worry about that they really shouldn't worry about.
Well, that's a tough one. Something number 35.
Yeah.
Everyone waits. They're like,
that's a good one.
Yeah. They're like, I'm here because I'm hitting 35, right? 35, even in medicine, and not to say it's 37 that your abnormality rate goes up significantly. 35 is when it becomes 50-50. And you don't lose all your eggs at 35, right? Like, that's when I see, like, I'm 35 when I'm still single, so I'm here to freeze my eggs. I'm like, well, you're not going to lose them. It's not that. But yeah, that.
Oh, that was good. I like that. For rapid fire, you came up with that pretty quickly, actually. I like that.
The power of learning on Instagram. This is what I have to do all day.
One last thing for you. If women stopped waiting, minimizing their symptoms, and stopped putting themselves last, what do you think would be possible for them?
Oh, that's like the world is your oyster, right? And I feel like for far too long, forget fertility and everything from education to jobs to the house. I feel like just innately are caretakers. We put everyone before us right? And that can be anything. And I think that's one of the biggest my lessons that I learned over life, that it's okay to care about yourself. It's okay to put yourself first. And if you don't put yourself first, no one else is going to put you first. So I think take out fertility, take out medicine, just in life, like, love yourself the mostest. And that's when others will start loving you the way you want to be loved.
Yeah. Oh, beautiful. Thank you. Thank you so much for being here today. Where can our audience find you and learn more about you?
Yeah, you can find me on 2.health, or you can find me at Roohi Jeelani MD on any of the socials. I'm really bad at TikTok. I try, but it's like chaos. My brain can't
Yeah.
do well with it. But yes, you can find me anywhere on social with my first and last name.
Beautiful. Thank you so much for being here today, and so excited to have you.
Thank you for having me.